Okay. All right. So thanks again, everyone, so much for being here today. We have Stephen Merlin and Ben Perry here today to talk about their journeys, along with also Steve is going to answer quite a few questions. And yeah, with that being said, I'm going to hand it over to them to do their introductions. Thanks so much, guys.
Hello, everyone. Thanks for joining us today. Being recorded, that's right. Just before we start, I wanted to talk just quickly about just make sure you have your mute on in case that we're in the middle of something talking, and sometimes someone will say something to their partner and kind of interrupts the flow of everything. Before we get going, those of us who are here on Monday nights, we just wanted to pay some respects to a friend that we all know quite well. Mark Ayton passed away, would be 2 Mondays ago at 11 in the morning from a long struggle. So those of you who didn't know that, I'm sorry to break it to you now. Those who know us well. And as we had said during that meeting, we all talked about his humor and his fight, his nigu, never ever give up. And I mean, we all have great things to say about him, but today we're here to ask Steve some questions and some answers. So what we're hoping for today is if you have a question like right now in on your head, you want to send it in a chat to Aaron. Aaron will let me know. We do have a list of topics for Steve to answer initially, but if you have one, we're going to go directly to that. I can't say right away, but as quickly as we can once we finish with the first two, I think, or three that we have up here. So I'm hoping everyone's in a beautiful, relaxing area to sit and listen. So we're just going to give Mr. Steve Merlin, we're just give him a brief case history leading up to his diagnosis of EUS. And if I'm saying it wrong, Steve, you're going to correct me when I'm all done. And biopsy of cellular pathological results, Whipple surgery, tumor board decision, patient advocate for aggressive treatment, genetic testing, precision medical targeting, therapy, clinical trial, long-term surveillance with imaging and ctDNA. So before we get into that, Steve and I slightly chatted about this. Both Steve and I were stage 4 um, pancreatic cancer patients. Steve's was quite fortunate to have surgery within 2 weeks, I believe it was, he told me, right directly after he was diagnosed. Mine was about 4 months later. Um, I went from a stage 4 to not eligible for surgery, went on the gemcitabine, basically the palliative care chemo, uh, for 3 months, and then I was quite fortunate to reduce the lesions on my liver. So I was eligible for surgery on June 17th of 22. 10 years prior to that, in June 18th of 2012, Steve had his surgery. And then afterwards, we do know of a lot of people who might have stage 4 cancer and they don't want to share and talk to people about it. But Steve and I are both, we're out there trying to make a difference in pancreatic cancer people's lives, patients' lives. So I'm going to send it off to Steve, and we're going to have a great day. I'm quite excited about this today.
Okay, thanks, Ben. Welcome, everybody. And I see a number of names of people that I know from the different Facebook groups that I'm on. So glad to see you here today. I'll give you a quick rundown of my diagnosis. In approximately May of 2012, my initial symptom was darkening of the urine. And I have this bad habit of working all day long and not taking any water or meal breaks to get the job done. And I'll work until it gets dark out. That's what gets me to stop working. So my urine was starting to get dark and dark like tea. So I figured I was dehydrated. I started to hydrate more, drinking copious amounts of water, and it wasn't making any difference. So after 5 days of no change, I went to my primary care physician. I have two of them, one locally here at the New Jersey Shore where I live, and I had another one very close to where I worked in Manhattan at Weill Cornell Medical College. So I figured the one in Manhattan would have a much bigger, diverse patient base, would be more likely to recognize the kinds of symptoms I was having. I went to him. The words that he said to me were, well, you look like the picture of health. Your vitals all look great. If you don't feel better in a week, come on back. And this was actually on a Tuesday that I went to see him. So I went back at the end of the week, a few days later on a Friday. I wasn't feeling any worse, but I wasn't feeling any better. And I told him my concern that generally after 3 days, I would start to feel better. And this was kind of going on, that maybe we should start doing some tests. So he agreed. He drew blood, ordered a bunch of tests. I had trained originally as a medical technologist. I knew the kinds of tests that were done if you had issues with your liver or your gallbladder. I was thinking that maybe I had an issue with my gallbladder because at the time I was 55, the same age in which my father was diagnosed with gallbladder disease. So he told me he would probably get the test results over the weekend and head into his office first thing on Monday morning on my way to work. Well, when I got home that evening, I looked in the mirror and I started to suspect that I was getting a touch of jaundice. My friends didn't mention anything to it. I was fairly had a good suntan at that point, so it was a little bit hard to tell. But when I looked at the whites of my eyes, they were clearly yellow. And then I looked on the inner surfaces of my forearms and they were clearly yellow. And then I looked at my fingernail beds and they were yellow. So I was definitely jaundiced. So I sat it out on the weekend. I went down to the beach because if you lay under sunlight, the ultraviolet light will break down the bilirubin. So that helped with the itching sensation. I went back to him Monday morning. He looked at me and he sent me right away for a ultrasound, the kind where they use the paddle when you're pregnant to check the fetus. And they were looking to see if they could detect any gallstones or sludge in the bile duct. That was negative. They called my physician, who then told the clinic, have me walk directly back to Weill Cornell where I worked. There was a physician that was a colleague of my primary care physician that they went to medical school together. His colleague happened to be a hepatobiliary surgeon, and he was waiting for me in the waiting room when I got there. So he took me right in. He ordered a stat CT. So that was done immediately. And then he told me head back up to his waiting room. And by the time I got to the waiting room, he already had the initial radiologist's interpretation, which said it found a mass in the head of my pancreas. At which point he told me the following morning he would do an endoscopic ultrasound known as an EUS. That was done in the morning around 9 o'clock. It was a short procedure, took about a half an hour. And I was told that he was able to get cells doing what's called brush cytology. The other way is where they can do a fine needle aspirate. So from the quick pathological examination of that, it confirmed the cell type which I had, and that it was a carcinoma. So I had a very rare one. It's found in about 1% of the people, called acinar cell carcinoma. The acinar cells are in the head of your pancreas, and they're responsible for producing and secreting the digestive enzymes. The next day, I had an endoscopic retrograde cholangiopancreatography, which is called an ERCP. And that was used to insert a stent to open up my bile duct. So this was now on a Friday morning. Everything was in place. I had all the final information at 1:30. The surgeon tells me I was eligible for having Whipple surgery. At the time, it was about 15 to 20% are eligible for that surgery. And I had a bunch of papers to sign. And he gave me a little booklet and he asked, did I know about the Whipple surgery? And I said, yes. When I was a med tech, I used to sit in on physician grand rounds and I learned about Whipple surgery and treatments for pancreatic cancer, of which there was not very much in 1979, 1980 when I was doing this internship. So I signed all the papers and I said, oh, by the way, I forgot to ask you, but when do you want to do the surgery? And I figured he's going to tell me within 7 to 10 days. And he said, tomorrow morning, we'll roll you in the OR at 6:30 to start prepping you in the morning. And I said, wait a minute, isn't today Friday? You're going to do surgery on a beautiful June Saturday and give up a round of golf? This must be serious. And he chuckled and he goes, no, it's serious. He didn't tell me that what they found in the CT was that the tumor looked very close to my portal vein. And so They had a very small window of opportunity. He wanted to get in there quickly and do the surgery before the tumor came in contact with the portal vein, and then the surgery would have been off the table. So they opened me up, and lo and behold, the tumor was already in contact with the portal vein. So about 95% of surgeons aren't equipped to handle that. They don't have the vascular surgery skills. The 2 of the 3 surgeons on my team also did liver transplantation. So they're trained in vascular surgery. They turned to the pathologist who was in the ante room, and they said, we're willing to continue doing the surgery. Do you concur to go on? And thankfully, he said yes. So they did a portal vein resection that added 3 extra hours to the surgery, 3 units of blood. My surgery ran 9.5 hours. And then I came through that fine. I started walking the next day after surgery. A week later, I wasn't having any bowel movements, and it didn't sound like there was any movement in my intestines. So they thought there was a intestinal blockage from the surgery. And I kept saying, no, it's most likely that I was not eating anything leading up to the surgery, figuring when you go for a colonoscopy, you want to have a clean GI tract. And then they started telling me, no, you're supposed to be eating. Well, they send me down for a CT, and I come back from that, and I'm greeted by the residents, and they said, yeah, you were right. There was no blockage that we found. But they never told me that the radiologist detected the beginnings of metastatic disease to my liver. So it turned out that I was stage 4 when they did the Whipple, but they didn't know it. And that's how I ended up getting the Whipple. And the team, I'm trying to think of the name, the tumor board, they meet, unbeknownst to me, they're evaluating all the different cases. They come to mine and they decide, knowing that I was stage 4 and I didn't know it, they would put me on Gemzar. So at the time, Abraxane didn't exist. This was in 2012. And in my notes of my case history, it said that that was chosen for palliative care, not curative. So here in my mind, I thought, hey, I've got a good shot at it, and that they were going to give me curative care. Well, it was palliative, just to keep me comfortable until it was time to go to hospice. So I didn't realize this until 3 months later when I got my first results of a CT done since I was on Gemzar. And now those micro tumors were now quite large. I had no effect with the Gemzar. I'm 1 in 10% in the population where my liver doesn't make the enzymes needed to break down Gemzar, so it becomes toxic metabolites. Excuse me. So I reminded my oncologist of the early discussion we had that I was willing to do FOLFIRINOX. I knew about FOLFIRINOX. I knew what the repercussions could be from it, the side effects, the adverse events. I was willing to accept those. And then they finally put me on FOLFIRINOX at full dose. This was the FOLFIRINOX that came out in 2011. It's 20% higher in its components than what you find today in M-FOLFIRINOX. I handled it extremely well. They gave me lots of different antiemetics to take to prevent nausea, anti-diarrheal agents. I took all of these proactively instead of waiting for the symptoms to occur. So by being proactive, I had a much better patient experience because it was preventing these symptoms from occurring. So in the 27 months of chemo that I did, I never got nauseous. I never vomited. I had some diarrhea, and that's primarily because they never put me on the digestive enzymes like Creon or Zenpep. And so I couldn't digest food, and the more I ate, the worse the diarrhea became. So my quality of life could have been much better had they been proactive and given me a pancreatic paste right from the beginning. So I responded extremely well to the FOLFIRINOX. During this time I was on FOLFIRINOX, I knew from my training that a clinical trial was probably going to be of importance to me, especially since the treatments for pancreatic cancer are very limited. So I began my search. I had no idea what to look for. It was like a needle in the haystack. I'm reading clinical trial after clinical trial, trying to see if something sounded really interesting. It wasn't until after the first 3 months being on FOLFIRINOX, when they saw that I was having such a robust response, that the light bulb came on with my care team and said, they asked me about my family history, which I had given when I was first diagnosed. And I told them that my mother died of breast cancer. My grandmother, her mother, died of breast cancer. My mother's first cousin, whose mother was the sister to my grandmother, for any of you genealogy fans out there, it starts to get complicated. She had breast cancer and eventually died from it. And the two daughters of my mother's first cousin ended up getting checked for the BRCA breast cancer mutation and found that they had it. So that's when my mother's first cousin then got tested for the BRCA mutation. My mother and grandmother had breast cancer before the BRCA mutations are really known, so they were never tested. So they tested me. I have the BRCA2 germline mutation. I then told my brother, go get tested. He listened and he got tested right away. He also has the BRCA2 gene mutation. So he was able to get on a surveillance program, and he goes through this surveillance once a year for potential early detection should he develop pancreatic cancer. So in the family, all the females were affected by that BRCA mutation having breast cancer. I was the only one that ever came down with pancreatic cancer. So using the information of the gene mutation I had, I started to go on websites like clinicaltrials.gov. I contacted Pancreatic Cancer Action Network in the US. They have a search finder service, like Craig's Cause in Canada has a search finder service. I gave them the information on my genetics and they were looking. I ended up finding the trial on myself. It was a unique story of how I came across it and then made PanCan aware of it. So I became the first patient in the United States that was enrolled in that clinical trial. And at the end of the trial, I was the one that had complete response and was able to continue on the drug, even though it's not an approved drug. So my oncologist had to write a protocol for one. She applied to the Food and Drug Administration in the US, asking for permission for me to continue on this drug under compassionate need. The FDA within 24 hours responded and gave the okay, in which turn the manufacturer of the drug then said, okay, we will provide it. So I get the drug free of charge. I'm on it almost 10 years now. I have really, the only side effect is occasional anemia, which is taken care of by short pauses and everything bounces back up. And here I am. So I'm open to any questions, or Ben, if you wanted to ask, start off on some of the questions. And you're still on mute.
I was being polite being on mute, right? I see
Yeah.
that we have a question up there, but we're going to get back to the BRCA gene question there. That's one of the questions that we're going to have. Okay, why is pancreatic cancer usually found in later stages?
Okay, great question. So the pancreas is deep in your abdomen. It's sits just below your liver. Part of your stomach is in front of that. And generally, there are not many critical structures where if you start to develop metastasis, that it would trigger symptoms of pain or other types of symptoms. In my case, mine was in the head of the pancreas, and it was situated right by the bile duct. So what it was doing as it grew, it started to compress the bile duct. And when the bile could not flow into my intestine, it was then backing up, and that creates the jaundice. When you have a tumor that's more on the body, and particularly the tail of the pancreas, there really isn't anything critical there. So it could grow, get quite large. The unique thing about pancreatic cancer, unlike other cancers, is that it is able to metastasize much earlier in its stages than other types of cancers do. So you can now start having metastatic disease, and until it grows sufficiently and it's hitting something that's critical, some people will start to feel pain in their upper back between the shoulder blades, a little bit more to the right of the spine. And what's happening there is where the tumor is situated in your pancreas, it's pressing against a nerve bundle called the celiac plexus. So there's a lot of nerves that come into that area. And now that celiac plexus nerve bundle is being pressed by the tumor, and it's got behind it your spine. So it can't move out of the way, and you start to feel that pain. So that's usually a trigger. Some
Good.
people might start to get some digestive issues where they have a lot of gas formed when they eat certain foods. They start to burp. That becomes some of the earlier telltale signs. But a lot of people just have no symptoms at all, and by the time it's found, it's already metastatic. And that's exactly what happened to me. My only
Yeah,
symptom.
in my situation, it was somewhat similar. We didn't know, Karen and I didn't know, like I was slowly turning yellow. And when you're with someone all the time, you don't notice those gradual changes. And it took someone somewhere outside of home who said, hadn't seen me in a couple of months, said, Ben, you're looking yellow. But I did have the lower back pain just on my right side, just above the waist. And everyone was saying, oh, you need to stretch, you need to do this, you need to do that. Bathroom breaks in the morning before I left the house, thought it was coffee, thought it was eggs, thought it was gluten and milk, and none of that. It was slightly helping, but not enough. But I think we had talked about at one time that it was maybe I'm wrong, but 17 years it takes for the pancreatic cancer tumor to start to grow from its initial, uh, you know, uh,
Right.
is
So,
that right?
yeah, so it's kind of hard to fathom that. There were studies done at Johns Hopkins University. The MD PhD that wrote the seminal paper on it was Christine Iacobuzio Donahue. She's now at Memorial Sloan Kettering in New York. And what they found that the initial changes from that very first one of the cell, it takes about approximately 11 years until you get a mutation which is able to remain. That most mutations are toxic to the cells, and so the cell will die. It's a fatal mutation. But the one that can remain and is viable, then at that point, it's about another 6.8 years until it becomes visible and manifests as a tumor and you notice it. And, when you're thinking about that, so it's about 17 years. And sure enough, when you look at the cases that occurred from people that worked at Ground Zero at the World Trade Center after the 9/11 attacks, or soldiers that were in Iraq and they worked the burn pits where they had these open pits that they were burning all kinds of chemicals and plastics and things taken out of laboratories in Iraq. 17 years later, they were getting their diagnosis. And I mentored a few of these people, and it was just astounding that, just like what that paper said, 17 years, it was 17 years when they started to get the diagnosis of it. So
Yeah.
I tried to think back 17 years from my diagnosis. What was I doing? Well, I was working in a clinical research lab in Switzerland. I wasn't exposed to really any hazardous chemicals. Mine was clearly genetic with the BRCA2 mutation.
Yeah, I just got my blood work requisition last week. I go in a week and a half from now to get it to see if I have the BRCA the mutation, because my sister had breast cancer as well. Steve, we're rolling into some questions here, so let's go the first one. Okay, I think it's Aaron. You'll correct me if I'm wrong. No, no, no. That's the first one I had it just. Yeah, do providers now test people to see whether they can break down the Gemzar before they use it for treatment?
Good question. So usually not. What they are starting to do, at least here in the US, there's a couple of gene mutations. One is DYPD. So that gene is responsible for an enzyme which metabolizes 5-fluorouracil, also known by the shorthand 5-FU. If you can't metabolize that, then you start to have some nasty side effects from it. The other one is called UTPA1A. and that's responsible for a condition called Gilbert syndrome. And in that one, you can't metabolize the irinotecan component, which is in FOLFIRINOX. So what happens is your bilirubin starts to go sky high. They have to take you off it, let your bilirubin numbers come down, and then they might try to use a lower concentration in the irinotecan of the FOLFIRINOX to see if you can tolerate it. So more and more oncologists are becoming aware of that and starting to test their patients before they start them on that to make sure that they won't have any kind of side effects.
Okay, great. Thanks, Steve. Next question from Chris. Sorry, and the last one was from Mary. Chris, I'm just wondering if the Whipple procedure is open for laparoscopic surgery.
So
Laparoscopic, yeah.
yeah, so yes, there are some that do it. But then if they discover something which they didn't see on the CT or an MRI or an EUS, then it gets converted into the open. Same thing with robotic. I hear where a lot of people are saying, oh, go ask and see, have it done robotically. Well, there's very specific conditions, and they do robotic ones when it's very simple and straightforward. And with me, if it had started off as robotic, clearly would have become an open classic Whipple, because what they couldn't see until they opened me was that my tumor was in contact with the portal vein. The benefit with robotic, when it can be done, is that you have a shorter healing time. There's less incisions made. So that's clearly a benefit. There are several places in North America that do that. I know Sloan Kettering is one of the places, and I know one of the surgeons that does that there.
Okay, that's great. So, Steve, I don't know about you, but I'm quite proud of my 10-inch or 9-inch scar that I have on my belly. But I know mine wouldn't have been able to be done that way. Apparently, the vein that runs through my liver is on the opposite side to other people. And I think she said there's only 3% of the people on the planet who are freaks like my liver. So unfortunately, well, then again, I do enjoy my scar. So it's a good topic of conversation.
And do you have a midline scar or the classic chevron?
It goes down, stops near the belly button, and whips around it, and so
That's
that
the
was the
midline.
biggest the part to heal, the whip around the belly button. I think they didn't quite get the staples in there, or maybe I was lifting too much weight too soon. Who knows? But anyhow,
Yeah.
and what did yours end up
So
getting?
I have the chevron, and I've asked surgeons, why do they do a midline versus a chevron? Most of the answers were it was the way they were trained, but sometimes based on your stature. If you're a smaller person, it might be easier for them. Everything is more compact. Like me, I'm only 5'4". They did the classic chevron. Other people, and particularly people that are a little bit taller, they tend to get the midline.
Yeah, I meant to ask you this many times. So I know you said your weight is low now, but what had you started off with? I started off at 198. After surgery, I was down to 150, and I'm back to hovering around 160. Like I say many times, if I'm complaining, I'm still here. So it doesn't matter, but it would be nice to have some of that muscle back for work, but I can live with that. So what did you start at? And I think you said you're down to below 130, right?
So I went into the OR at 136. I came out at 117. And a few days later, I dropped down to 114. So that
Oh,
was the lowest. I was extremely thin. Uh, Today, I'm at 130. So I've
okay.
gained back most of it. And so I'm really comfortable at that weight. I'm not looking to go back to 136. For my body mass index based on my height and my age, I'm at the ideal weight. So I fluctuate between 127 and 130, and I'm happy at that
I
amount.
would kind of like to be back to 170, maybe 75, but and you know what? I'm still here complaining. I don't really care. Okay, Gail asks us, how long were the pauses in your medication when it became too severe? Was that
I'd say,
anemia?
yeah,
Yeah,
that's probably anemia,
and a hypoglu, yeah, level is a pause.
right? So the first symptoms of anemia came exactly 6 years that I was on the PARP1 inhibitor called rucaparib. The marketing name is Rubraca. It's the biosimilar to Lynparza, also referred to as olaparib. I had shortness of breath. I'd walk up a flight of stairs. I'd be really out of breath. If I was squatting down, working on my lawn, and then would get up, I would get extremely lightheaded. I'd get syncope and feel like I was going to fall. So at my hemoglobin was somewhere between 7.1 and 7.5. They give you a transfusion when you hit 6.9. So I did a pause. I also said that I was willing to do a bone marrow aspirate. Nobody in their right mind asks for a bone marrow aspirate. And I know how they're done because I used to work in the lab and assisted pathologist. It's a much better way they do it now. So I was quite relieved when I got the bone marrow aspirate. That was to check to see if there were any anomalies in the blood cells in the bone marrow that are precursor cells. And thankfully, there were none. That it was clearly proven that it was the PARP1 inhibitor, which was suppressing red blood cell production in my bone marrow. So I did a 6-week pause, and then my oncologist suggested going down 1 dose reduction, which I did. So rucaparib is dosed differently than Lynparza. I was taking 1,200 milligrams a day. We dropped it down to 1,000 milligrams a day, and everything was fine until about a year and a half after that first pause. And then I started to feel the anemia again, and it was somewhere down around 8.1 this time. So I didn't want to do another dose reduction, which I could have. Instead, we did a pause again of 6 weeks. I felt great. Creatinine level goes back to normal. The estimated glomerular filtrate rate, which is a measure of your kidney function, went back to normal. Red blood cells and hemoglobin bounced right back up. And then it's slowly a downward slide. So I'm monitored every 6 weeks because I had been on that clinical trial, and I'm the longest person in the world on this particular PARP inhibitor. So I know, monthly what I'm running as far as the anemia. So right now, my last pause was about 2 months ago. I feel great. I've got a lot of energy. I've been running neighbors' dogs. I don't get winded. So it'll be interesting to see whether at this point my body is tolerating it better after a second pause, or if I'm going to have to do another pause at some point. So far, it looks like it's been on a frequency of about every 6 months.
Okay, that's great. Thank you.
Thank you for that.
Thank you, Steve.
Yeah.
Okay, someone has their button off. Yeah. Gail, can you mute your button there?
Yeah, I just said I wanted to thank him for that answer.
Okay, all right. Thank you, Gail. Laura asks, and I'm gonna take a guess it was the Genbrac cocktail, but gemcitabine, I mean. What was the name of the first chemotherapy that you did before the 4Fs?
So
The
that was
FOLFIRINOX.
that was Gemzart, also known as gemcitabine.
Yeah, the gemcitabine. Yeah, that's what I was on, and we didn't know until after the fact that that's the palliative care chemo. Well, I think he told us up front, but it kind of went in one ear and out the other because you're like, oh, I have cancer, I need chemo. So, but if and moving forward, if it was to restart again, knowing what I know now, I might have asked them for the FOLFIRINOX up front and just live with the neuropathy. But I mean, I did get good results from that. But I did change my diet, and when I tell people I changed my diet, it wasn't so much that I was eating unhealthy. I was eating a lot of foods that were causing my stomach issues. So, anyhow. We'll move on from there. Okay, Megan asks, has the medication you've been using for the last 10 years become an option outside of trials? Do you believe it would be effective for adenocarcinoma?
Okay, Gail, good question. So yes, it is FDA approved. The drug which received approval for pancreatic cancer applications is Lynparza, made by AstraZeneca. Its generic name is called olaparib, and that received approval in, I believe it was 2018. The drug that I'm on was from a smaller biopharmaceutical company that was running low on money. They were trying to get approval. first for women with ovarian and breast cancer, since that's a much bigger market. They did secure approval by the FDA for ovarian cancer. And then they were trying to pump all the money into breast cancer, since that was the next biggest market where they could recoup some of their investment, which didn't happen. They ran out of money, went bankrupt, the assets were sold off. But before that happened, they also got approval to use rucaparib for prostate cancer. So right now, the only one is Lynparza. However, in people that are on Lynparza, should they have some type of intolerable side effects from it, their physician can prescribe rucaparib, and they can take that. So it would be like an off-label use, which is okayed by the FDA.
All right. Thank you, Steve. That's a great question. The next question, I hope I'm in order here, from Mary. Do you have any knowledge about the, I think it's ALIA, pulse electric field system for tumor treatment?
That one I don't know. I know about NanoKnife, irreversible electroporation. And what they do is there's very fine metal probes that are inserted around the periphery of the tumor, and then using microbursts of high voltage, they create a electrical field. So they use between 4 and 6 of these probes to surround that tumor, and then they'll send current between probes 1 through 2, then 1 through 3, and so on. So it limits any collateral damage to healthy tissue around that tumor. And NanoKnife is also known as irreversible electroporation, or IRE. And what that means is it causes very small pores to occur in the cell membrane, and they're irreversible, meaning that they can't heal themselves. So what happens is it causes the cells to go into apoptosis, which is known as programmed cell death, and the cells die without going through a stage of necrosis. It does it by apoptosis, which is easier, and you don't start to get a type of response because of the necrosis where you get inflammation. One of the benefits of that technique is what's called the abscopal effect. And what happens when these cells start to die off and they're exposing more antigens or proteins that are on the surface of the cell, your immune system starts to recognize that and say, hey, I see something foreign here that shouldn't be here. I'm going to go attack it. So your certain immune system cells, antigen presenting cells, macrophages, and so on, all work in conjunction with each other, and they will start to then attack the remains of that tumor. So it's sort of like a 2-for-1 beneficial effect in doing that. And there's a few other types of treatments that they're observing this abscopal effect that occurs.
Okay, thank you, Steve. There was, the weird thing is having ADHD, things pop into my head when you're speaking, and I want to touch on that. And okay. All right, gonna move along here. These questions also abandoning Thorn. Did you ever have to modify it based, I think it has to do with Fulflorinox, based on your blood test, either during the cycle without etanocan, or reducing the dosage, or taking a week's break? Far as me, I only had 5 rounds of the Fulflorinox, and I maybe initially when I went in, I was trying to tough it out like I did with the gemcitabine, and if it was making me sick with the gemcitabine, I just toughed it out, and we didn't change it. Perhaps when I went to the Fulflorinox, I should have spoke sooner and dialed it down, or take some nauseating meds for it, but I waited too long, and I ended up taking my my walker of medicine with me into the bathroom, and I didn't know whether to sit or stand. We'll just leave it at that. Steve?
So very
Did you
good
have
question.
to? Yeah, okay.
And no, I didn't. And you have to remember that I was doing the version of Fulfirinox, which was FDA approved and used from 2011 to 2018. And that's when M-FOLFIRINOX came in. So the difference is that that original version was 20% higher in its main components of 5-fluorouracil, irinotecan, and oxaliplatin. So one of the things I did, which helped me greatly in getting through it, first of all, I was in very good shape. I was an avid cyclist. I was doing long distance endurance bike riding. Even when my initial symptoms came on, I was still bike riding. And with the FOLFIRINOX that I was taking, I had full dose of it based on body weight. There were a couple of times where the oncologist looked at me and said, Steve, you're looking a little pale. Do you want to take a break? And I said, absolutely not. I said, as long as I can fog a mirror, let's keep going. And I did. So I used the antiemetics, the anti-nausea medications proactively. I started taking them when he first started with the infusion, and I took them for 3 days after. So some people say they'll wait until they got the symptoms and then start taking the drugs. And I think, why do that? The whole name of the game here is to try to get through this, with not feeling these symptoms, make it a better patient experience. So I'm always a proactive patient like that. Same thing with the anti-diarrheal agents. I would start to take it 24 hours before I would get my infusion. So there's a good level in the blood. And then I continued taking that till about 3 days after, which was usually about the time it took for the last infused drug to clear your system and not have any more of those effects. So I never did any dose reductions. However, there you can do dose reductions. What they do is they're giving it to you in excess anyway to begin with. So if you were to have a dose reduction, you're still getting a therapeutic dosage that's cytotoxic to the cells. There's another technique called, I got to think of the name here, metronomic dosing. So think about a metronome if you've ever taken piano lessons with keep syncopating the time. And what that is you get a much lower dose of the FOLFIRINOX, but you get it infused more frequently. And so a lot of people that were having difficulty with the FOLFIRINOX, when they use the metronomic dosing method with the lower concentrations, they're able to tolerate it much better and then get the desired effect. I know of several more elderly patients that were doing this. The goal was to try to get them to become candidates for the Whipple surgery, and it did work. And once they went from that initial normal dose to the metronomic dosing, they did much better. So metronomic dosing came about by a famous pancreatic cancer oncologist named William Isakoff, Isacoff. He practiced at UCLA. He's now retired, but he's still active in pancreatic cancer research. And he will consult with your oncologist if you think that metronomic dosing might be something of interest to try because you're having problems with the FOLFIRINOX at a higher dose. And he'll work out with your oncologist the amount to be given and the frequency of it.
Oh, I'm sorry, I'm just getting a call here. Yeah, I found I tried to, when I was doing my gemcitabine, I was quite afraid of getting sick, so I drank just mostly fluids during the day. I had some Gatorade and I had some vitamin water. I found that helped a lot to get through it, so I wasn't sick. And again, maybe I should have been taking the meds, but I didn't. I don't know. I didn't want to dilute the meds too much by taking too much food and too much meds. I'm kind of, I guess, in a way against meds sometimes. But when I went on the FOLFIRINOX, I found the more I ate, the better I felt. Yes, I did feel like I needed the meds a lot more, but the more food I had in my stomach, it allowed me the second, like the last 4 rounds to tolerate it much better. We didn't reduce the dosage at all, though. Aaron, do you want to take that next question? I actually, the one we were talking about, I got to step out for just a sec here.
No problem.
Sorry.
So the next question from Gail is, why is olaparib approved only for a germline BRCAN mutation and not a somatic BRCAN mutation? I would have thought the PARP inhibitor would be even more effective for a somatic mutation case because it would target only the tumor and not healthy cells.
That's a great question. And I've got to ask some of the experts on the BRCA mutations why that didn't occur. It does work in some people with somatic mutations. I happen to know one. Her story has been well publicized on the internet. Her name is Davi, D-A-V-I, D'Agostino. She had a somatic mutation, and she only needed to be on the PARP inhibitor for a little more than 5 years because, remember, somatic mutations are isolated to the tumor. They're not found in every cell of your body. So once you eliminate the somatic mutation or that tumor, you don't have any more. So she was able to stop her PARP inhibitor. I surmise that because the population of patients that have just a somatic BRCA mutation is far less than those that have a germline mutation, and they weren't able to do a conclusive study, having enough people in that study for statistical meaning for data in order to calculate that. So if you do have a somatic mutation, the oncologist can prescribe it off-label to treat somatic mutations, and they generally do. There's also a couple other mutations where it may be a benefit. Those are people that have the ATM mutation, PALB2, PALB2. That's another one. And so they're looking at other types of mutations where a PARP inhibitor may be of benefit.
Okay, Aaron, that wasn't the one from Mary, the question there, was it? Sorry, I had to step out there. The next one is this, or is this the one we just answered? Can you remind us about the type of patient? Is that the next question?
Yep, that's the next one.
Okay, the type of patient that needs, that tends to respond to the PARP inhibitors, I think maybe just for those with the BRCA1, 2, or PAL 2 germline mutations, but not ATM mutations.
So
It's a
now
mouthful.
and then there's a rare person that might respond to it that is outside of the BRCA or PALB2 mutation. And so they will try them. What they found that in people that are getting a platin agent, so a platin agent would be oxaliplatin in the FOLFIRINOX, cisplatin, which is given in patients that have Gemzar, Abraxane, they'll do a triplet and add the cisplatin to it. So when they see people that are responding extremely well to that, that's usually a light bulb comes on saying they might do well trying a PARP inhibitor.
The next question, thanks again, Steve. There, next question, it's one of the ones that we had a question on. It's about NanoKnife technology to treat stage 4 pancreatic cancer cases. I know of only one surgeon who was doing this in cases. Yeah. So what do you think of using NanoKnife?
So it's definitely something that should be looked into, especially if there's a tumor that's getting involved with the vasculature, because with the NanoKnife, it doesn't affect the vasculature. There are several places in the US and Canada which do that. There's the most experienced person is down in Florida, but also there's two others with very high experience. One in Louisville, Kentucky, at the University of Kentucky. There's another person in Baltimore. And actually, there's a third one, Dr. John Chabot at Columbia Presbyterian in New York City. He does NanoKnife when the situation warrants. And there's more. So actually, if you go on the site called angiodynamics.com, that's the maker of NanoKnife. You can put in your zip code or postal code, and it will come up and tell you within a certain distance who in that general geographic area performs the NanoKnife procedure.
Okay, great. The next question, I should have kept reading. I started it anyway. My mother's having, this is from Megan. My mother's having Whipple surgery in 3 weeks. As a caregiver, what can I expect upon seeing her right out of surgery? 2, with a negative prognosis of pancreatic cancer, how, as a caregiver, do I believe you can best support a patient? I can tell you when you first wake up, because it was just 2 years ago, my surgery, that you're quite groggy and they are going to look like they may have been dragged through something because it's a long procedure, between 5 and 10 hours. Mine was 10, I believe Steve's was 9 hours, and it definitely takes a lot out of the patient. But as far as a caregiver, and Aaron, we do have a caregivers group, so that's something that on Monday nights you could pop into and ask your questions there to all the people who are giving care to these people. But Steve,
Yeah. Well, when I worked as a med tech and I would used to ask patients that I had to draw blood from how they felt, they would, and these are people that, also didn't have Whipple, but other kinds of procedures. And they would say, I feel like I was just run over by a truck.
yeah,
And what could I relate to that? It was amazing that here I went into surgery in top physical form. I was doing 100, 200-mile bike rides every week leading up to this. And when you come out, that your lung capacity is so much diminished. They give you what's called a spirometer that you blow into and you try to lift those balls up. And so I could get 1.5 up, whereas I'd have no problem doing all 3 of those before I had the surgery. And so you have to build up your lung capacity again. You have to build up your strength. And the first thing I started to do was after a good sleep after that surgery, I got out of bed. I sat in a chair for a while. I did a short walk. The next day, I did a walk around the ward in the hospital. So I was in New York City. The wards are quite large. This hospital spans an entire city block. And each day, my goal was either walk a further distance, do more laps, or more time walking. And eventually I just lost count. I just kept walking and walking. Between meals, I would walk. Anytime I could get out of bed, I was walking. So that really helped build up my endurance again. And I started to feel much better. I made it a rule that I got up, I washed, I shaved, I brushed my teeth. I tried to make my normal daily living habits back to what they were. And mentally and emotionally and physically, I was feeling much better by doing that instead of lying around in bed.
was that in the hospital or once you got at home?
So yeah, so that was in the hospital.
Yeah,
And,
yeah.
and my goal was, to get out of there as quick as I can and get back to normal. I had several caretakers. My brother was the one which spent time while I was in the hospital. So he was always making sure that things were within easy reach on the table. That I was always left when he went home, that the phone was charged and was within easy grasp. And just making sure that all of my needs were met while he was there, and that I was equipped when he was gone, that I, had everything. So that made it much easier.
I
Uh,
was quite lucky. Like mine was during COVID, but we lucky that for us we accidentally got a private room, so Karen was able to come in and hang out with me all the time. But when she wasn't around, like I remember waking up one night at 4:30 in the morning, and I couldn't sleep. I just from lying on your back all the time, I was getting, I wouldn't say bed sores, but it was sore on my back. So as I was shuffling around, and then the nurses at the stations are looking at me while I'm going through the hospital, and I had my phone with me all the time, and I was mapping my walks. But daily, I was putting in between 2 and 3 kilometers, not walking, I'll say shuffling. One day, Karen came in and we went for a walk together, and she was walking like crawling. I'm like, honey, I can't actually move faster than this. Let's go, let's pick up the pace. And I think on the third day, maybe stupidly, I started doing push-ups off the edge of my bed because I wanted to get out of the hospital. Like, I was feeling healthier, and then as I'm walking by all these patients in their rooms, they're all lying there in bed, and like I never see anybody walking by my room, and I'm like, people, you should be moving. It's, get up and get moving. So Steve, again, you and I draw similar situations.
so,
Okay.
I just want to add
Oh,
to
sorry.
that for comfort. So I had told my surgeon, I know that, they restrict you drinking water, and they give you these ridiculous little foam rubber things on the end of a stick, and you're supposed to moisten them. And so I told my surgeon, I said, look, I come from a medical background. I know all about the reason not drinking water, this and that. I said, but there's nothing worse than being extremely parched. It's the worst feeling in the world, and that you can't drink anything. I said, will you allow me to be able to take some water and rinse my mouth out, at least to wet the mucosal membranes in the mouth. And he said, fine. And he wrote that in the orders, or I could put like a couple little ice chips in there. That made a big difference. The other thing is, I remember right after my surgery, and then I slept it off. It was 5 o'clock in the morning following the surgery. I had the most excruciating pain. You know, when they show you that little chart with the faces and point to the face that represents you, and 10 is the worst. Well, I had 11 out of 10. And it was likely because you're immobile on that table for hours when they're doing the surgery. And I had the worst knot up here in the back of the shoulder. I couldn't reach it. You're stapled, so you're not that flexible. And thankfully, they allowed my brother to sleep over in the room. I had a private room. It just happened to be that way when you first come out of surgery. And he was able to work the knot out because the nurses weren't going to do it, and not 5 o'clock in the morning. And then I had another one hit me about 7:30 on the other side. And again, my brother was there to work it out, and I didn't have any issues with the horrible pains from the tightness of your muscles because you were immobile for such a long period of time.
So I do wonder if anyone in the audience here has had Whipple surgery. And Steve, you're probably like me. They say you can get out of the hospital once you have a bowel movement. And I remember coming out of the bathroom and I was like cheering, like you know, when your child first makes I made potty, mommy. And that's how I felt like it. So I was like, oh, I'm getting out soon. Okay, and I probably can answer this next question somewhat. What do you know about alternative complementary treatments? And the word there, complementary, very true, I believe, to chemotherapy, like intravenous vitamin C, herbal supplements, the blood pathogens, and other supplements. I can say that in the end of it all, I do think they're complementary. There's not been enough studies done on them yet, and we tend to wonder why. But I, unless the doctor says do not do this, do not do this, I would, yeah, that would be my answer.
All right. So I was just recommended to take a multivitamin, the mineral zinc, which is essential for immunology and your immune system health. And then a couple of vitamins. I think they told me B6, B12. I took calcium D3, make sure I was getting enough calcium. But integrative medicine, so you can look at in a lot of the larger comprehensive cancer centers, they'll have a complementary or integrative medicine oncologist, and who will work with you on different things that you can take. So, you know, some people will see things on Facebook, I'm taking this and that. Turkey tail mushroom comes to mind, other stuff. So you have to be careful because remember, everything gets processed through your liver. Your liver is under a lot of strain when you're doing chemotherapy. It requires a lot of enzymes in there to break down the drugs that you're getting into toxic metabolites. Then they may have you on other kinds of medications. So there's even more stress on your liver. So it's always best to check with the oncologist. And I found really the best person to talk to, which most people are unaware of, but the person that your NP or your physician assistant or your oncologist goes to for the definitive answer is the hematology oncology pharmacist. So who are they? Those are the people that work in the little satellite lab off of the infusion clinic, and they are specially trained in everything that has to do with chemotherapy and complementary things, supplements, and so on. So they will know whether there is a reaction when you're combining these things. And you have to remember there's a couple things that could happen. One is absolutely nothing. It has no effect on the medication that you're taking. Or what it could do is impede the processing and metabolism of that chemotherapy drug. So now what happens is that drug level starts to rise in your system and its toxicity is greater. So that could be really harmful to you. Or the opposite can happen where it negates the positive effect of the chemotherapy. And so now you're taking chemotherapy for naught because it has a negative impact on it. So these are the kinds of questions that the hematology pharmacist knows, and that's who your oncologist and NP is going to get these answers. So if you haven't been introduced to that member of your care team, next time you go for an infusion, ask the infusion nurse to make the introduction to the hemonc pharmacist. The way I met my hemonc pharmacist, person comes into my cubicle carrying the chemotherapy IV bag, wearing a white lab jacket, and I asked him, what is your role as on my care team? And he said, I'm the hemonc pharmacist. And I said, just the person I want to talk to. And I started asking all these questions, and they're great. They'll answer all the questions for you. So consider hemonc pharmacist somebody to become friendly with, because they really know this stuff inside
Like,
out.
yeah, just pick their brain. I do know in other countries, like in Canada, we don't have a very good integrative healthcare system here. And I know in the States they do, and there's certain places in Europe they use a lot of different like they're using Q-certain, for instance, I think it's Germ. Anyway, I'm not sure, but I know it's in Europe. They started using it for COVID, but they're using mistletoe
Yeah,
and,
mistletoe.
and a few other ones. But in Canada, they would never. Oh, do not take that, But I do know there was some stuff going around. People were saying use milk thistle, but milk thistle is really hard on the liver. So if you can find something maybe that protects your liver while you're taking the mistletoe, perhaps. But then again, I think we do have to look ahead and ask more questions, and not just say, "Oh, I read this online."
Right.
Good. There's a question here, Aaron. I think it's more for you. It says this question is more for you. It's about a video that was up about the nano knife. The
Yes,
next
yeah, I
one.
already answered that.
Okay,
Yeah.
perfect. Okay, we'll scroll to the next question. No, you did answer. Sorry. Okay, thank you. Okay, last question so far from the gallery, and then we do have some more if we want to continue to go. Yeah, because I do want to get back to the BRCA gene question, but we'll go here unless we have already covered it. What do you recommend for a patient not eligible for surgery, but had 6 sessions of chemo and 5 days of SBRT, NED for a year and a half, CT scans every 3 months? Is there anything else they should be doing? Not
So
eligible for surgery.
there's still other kind. Oh, and so the question is, are they NED at this point?
Yeah, that's what, like when I see NED there, I'm wondering for a
Yeah.
year and a half.
Yeah, right. Okay.
That's
So
from Anna.
you know, they use standard of care protocols. The National Clinical Cancer Network is used widely in North America and even some European countries that write these protocols. And so for the lower stages, it's basically a wait and see attitude. And there's a reluctance to give people beyond 12 cycles of, let's say, FOLFIRINOX or 6 months of Gemzar Abraxane. And so this is something that I wanted to mention. I'm glad you jiggled my brain about this one. So the question is, why do they give you 12 cycles of FOLFIRINOX? I would be asked this by patients that I'd mentored all the time. And as a scientist, I would start going through the scientific literature, trying to find out if there were clinical trials which came to the conclusion that 12 was the best number to use. And I couldn't find it. So one day I had the opportunity, I was on a webinar that Dr. William Isikoff, he's considered the father of FOLFIRINOX, and he was the one that came up with the metronomic dosing. He was on this webinar. I submitted a question, and he answered my question. And he said, well, likely it was a working committee of pancreatic cancer oncologists through the American Society of Clinical Oncology. They were having a meeting, and the question was asked, how many cycles of FOLFIRINOX do you think your average patient could tolerate and achieve NED status? And so the consensus was 12. So what does NED mean? No evidence of disease. It means that using conventional imaging, that could be a CT, an MRI, or a PET scan, that they can't see any evidence of disease. However, remember that each of those instrumentations has a threshold of sensitivity in detecting something. So if there are too small of events in your body, biological cells, to be detected, they could be there. It's known as minimal residual disease. So after treatment, that's what they would term it. So it could be down there, it could be quiescent. As long as your immune system is healthy, it's holding it in check. And so that's the goal of the oncologist, get you to NED, and hopefully your immune system, if there are any kind of challenges to it, is strong enough that will keep everything in check. But if there's a challenge and your immune system weakens, all bets are off. And then what happens is you get progression of disease. So you'll see that most of the time it's within the first 24 months that a person will have evidence of progression, and they can go out to 5 years. So I knew all about minimal residual disease. I knew the pioneers that worked on it in uh, blood cancers, leukemia, and lymphoma. And in those cancers, you get a lot of pediatric cases. All it takes is one cell that's remaining after their treatment. It could come roaring back and big problems. So that was a fear in me. It's like, wait, why are we stopping? If I feel good enough and continue to handle it, let's keep going and see if we can wipe out any minimal residual disease like they do for leukemias and lymphoma. So with stage 4, it's no problem because now it's a life or death matter that they would keep giving you beyond the 12. But when you're of a lower stage, there's that reluctance. And no oncologist is going to say to you, I think you should keep going, because you can have permanent damage, or you can have damage from the chemo, which might be short-lived, but it's very uncomfortable. However, if you're a patient and you say, look, I know all about the side effects from FOLFIRINOX, I understand the repercussions, I'm willing to go a little bit beyond since I'm handling it so well, would you consider in allowing me to go on? And some oncologists, if you are, physically strong, mentally and emotionally strong, they might say, okay, and they'll let you do it. So what I know now, if I had been a lower stage after my surgery, I would have said, let's go for some added insurance here. Now, a lot of them will argue the point saying, well, we don't really have any data to back this up, saying that if you were stage 2 and you hit NED, would going beyond the 12 be of any benefit versus the risk that it has? And so one of the things that everybody was concerned with was getting chemo-induced peripheral neuropathy. And, that's the big one when you get FOLFIRINOX. And so a lot of people don't want to continue, let alone get to 12, because they're getting the neuropathy in their hands and their feet. And with me, my attitude was, you know what? I'll deal with that new normal. It's better being alive and having neuropathy than dead. I can be a lot more productive alive. So I said, let's go for it. I did get neuropathy, but my oncologist, knowing that I was going to go well beyond the 12, the way he dosed me was he gave me 6 cycles of FOLFIRINOX. So that covered 3 months. We did a scan. The next 3 months, he took away the irinotecan and the oxaliplatin. So it was considered resting cycles. So now I'm just on 5-fluorouracil at full dose with the leucovorin, which is basically a reduced form of folic acid, which is a vitamin. It's called folinic acid. That kind of strengthens the effect of the other 3 chemo agents that you're getting. So the goal then was, he hoped that my tumors would remain stable, or if they did grow just a little bit until it was time to get back on full dose FOLFIRINOX again. The amazing thing that happened was I was still getting robust shrinkage only on 5-fluorouracil, which he said, they rarely see that. So there was something really unique about how I was dealing with the FOLFIRINOX. So I went on the 6 cycles of the resting, and then I went back on FOLFIRINOX again. So we kept alternating this every 3 months. And also that alternating might have also resulted in why I never developed any resistance to that chemo regimen over that length of time, which was 24 months. So they are using PARP inhibitors now. So if there was a patient and they were, say, stage 1, they had Whipple, stage 2, normally standard protocol would be wait and watch. You're finished with the surgery, and now we're just going to monitor you and give you CT scans and an exam every 3 months. And
Yeah.
now they decided, because with BRCA mutations, if it's a germline, you have added risk where it could come back, and it could either be a new primary tumor that's formed. So there is a clinical trial going on now called the Apollo EA2192 trial. I think they're still recruiting for it. But it is phase 3, which means that you're randomized. The computer can assign you either going into the control group, which is wait and watch, or into the test group where they're giving you Lynparza. And then they're going to compare you to the people that are in the control to see whether, if those on the PARP inhibitor gets to 5 years without any progression or new evidence of a new primary tumor. So oncologists are starting to get more open-minded now and think that, yeah, maybe if people can tolerate it beyond the 12 and they're willing to do it, to let them. And this brings up the point about the neuropathy. So when I did this in 2012, they didn't know about cold therapy. What cold therapy is, that if you chill your hands and your feet just prior to getting oxaliplatin, what it does is it causes the capillary beds in your extremities to collapse, meaning they get really tight, they constrict, and you can't get blood going through them. So during the course of the 120 minutes of getting the oxaliplatin, it's restricting any of that neurotoxic agent from getting to your peripheral nerves, and it's protecting them. After you finish the infusion 120 minutes or 2 hours later, you take off the booties and the mitts, your extremities warm up. At this point, the oxaliplatin is completely diluted within your bloodstream. So diluted, it's still plenty it's still toxic to your malignant cells. They're very fragile to chemos like this, but your nerve endings are no longer as susceptible. And so now you are having oxaliplatin going over the nerve endings, but at a diluted concentration, which won't damage them. And of course, you don't have to worry, because your fingertips and your toes are not hospitable sites for progression of disease and metastatic tumors to occur. So more of these bigger comprehensive cancer centers are now using cold therapy. There's booties and mitts that you can buy on the internet, on Amazon. They sell them. I think Erin may have the link. If not, I can send it to Erin and she can send you. I have several links that describes about this method that's used. So it's not a guarantee. It doesn't work in everybody, but in majority of people, it seems to be helping. They've done a couple of clinical trials. There is a current one right now at Columbia Presbyterian in New York City. And somebody got the idea to add on to that clinical trial using the cold therapy to try compression socks and gloves. So if you could restrict the flow in your extremities that way for people that have sensitivity to cold, that may work. So I don't know the results yet. It's still in progress, but I do know that a lot of people anecdotally are saying, I did cold therapy and it really helped me. I have no issue with the chemo-induced peripheral neuropathy. So when
Well,
you compare that,
you
people, yeah, they're more willing to continue through all of that chemotherapy.
all right, there you kind of answered two questions out of that one question. There's still questions coming in here, but I can say, like, I had 6 rounds of the gemcitabine cocktail and then 5 rounds of the other one, or sorry, yeah, no, 8 rounds and then 5 rounds. And I remember going in for my 5th round. Actually, I was supposed to be going in for my 6th round, and we saw the oncologist the day before. And I had telling my wife, you know what, I will go up to 10, which is what he said we were going to get. But if I don't have to, like, I won't. But if he says I need to take it, I'll take it. But it was a lot harder. And we talked to different people, and some people, they don't have a problem with the Florinox. They had the problem with the gemcitabine. I was the opposite of that. But when I went in, he said, no, you've already had enough. But I don't know, like, I was stage 4, and I know it can come back. And maybe if I end up having the BRCA2 mutation, that shoe I'm waiting to hit the other floor is going to get a little closer to the floor in my mind, you know. So I think there's 2 questions left here. This one is about, I think, no, just about a surgery. And I think, Steve, you and I talked on this, and if we can make it quick, because we're almost at an hour and a half. Are there any surgeons that consider surgery even when the portal vein is engulfed with a tumor? And I believe we touched on that quickly last night, so we can repeat that.
Yes.
Well,
So there are several here in North America as well as Europe. My surgeon was one of those. He's now back in Paris, France. So the 4 top surgeons that I'm aware of in the United States, which will do vascular involvement, are Dr. Mark Trudy at the Mayo Clinic in Rochester, Minnesota, Dr. Douglas Evans, who is at the Medical College of Wisconsin-Froedtert Hospital in Milwaukee, John Chabot, who's the head of the Pancreas Center at Columbia Presbyterian in New York City. And also in New York City is Dr. Christopher Wolfgang, who was originally trained at Johns Hopkins. He's an MD, PhD, and he does that. And then there are a few other, but those are the 4 main ones that I know that will do that. So if anybody is initially told by their surgical oncologist that, no, you're not eligible for the Whipple, then you want to get a second opinion from one of those 4, because those are the ones that are very highly skilled, that are able to handle the
yeah,
surgery.
and like you said last night, they know their limits. They're not gonna go past, you know what, I can't do that, but let's try it anyway. They won't be doing that.
Right.
So the last question, I think we should wrap it up here. Is pancreatic cancer a genetic disease?
So what happens down there at the molecular level is genetics, but of the pancreatic cancers which are genetic, is approximately 10% of all of those cases that are diagnosed. And we touched on BRCA1, BRCA2, PALB, STK11, CDKN2A. These are all genes that are associated with causing pancreatic cancer. Of the remaining 90%, those usually have to do with either lifestyle or environmental exposure. So environmental exposure is you're living in an area where there's pollution, or you're exposed to some sort of environmental toxins. Your house was built on Love Canal in Buffalo, New York. Things like that. You work in the chemical industry, or it's known that a lot of people that were firefighters, they worked with a particular type of foam that was used that's clearly linked to pancreatic cancer. So, that's one of the first things that when you are getting diagnosed, they will ask you and try to see if you had any kind of risk factors. The major environmental risk factor is smoking, number 1. And then another one close to that is alcohol. And if you're, excessive smoker and drinker, that seems to be a really deadly combination. And when I was a young med tech sitting in on the grand rounds at the hospital, I was amazed at one case after another that they were presenting. Person was a heavy smoker and drinker of hard alcohol. So we're talking things like, whiskey, anything that was 40 proof or higher, several drinks a week. Obesity is another factor in pancreatic cancer. So those are like the 3 main ones, which are all preventable by just modifying your habits, and also certain foods. So processed foods is a big one. You're eating things with lots of nitrates, nitrites, things like that. There's a higher incidence there.
All right. Thank you, Steve. I know when I went in, my liver counts were up, and my doctor, my GP said to me, he asked me how much I drank, and I said, it's 4 to 5 beer a week. And he said, well, that's your problem. You drink too much. And I stood up and I raised my voice at him. And I said, there's something else wrong. I said 4 to 5, not 8 or 10, not 12, 15, 4 to 5 beer a week. There's something else wrong. So thank God that if I had to listen to him and said, yeah, okay, that's what it is, I'll cut it back to 1 or 2 a week, I wouldn't be sitting here today. So and John, one of our friends who has passed, he said, be your biggest advocate, and I know the group of people here, we've probably most already have been diagnosed with a PC. But the thing is, when we share our story to other people who don't have it, emphasize that fact that we need to stand up for ourselves, and be our biggest advocates, because the medical industry, the science of medicine, it's still learning. If we look at it like 30, 40 years ago, no such thing as acupuncture in standard of care. And now, oh, I have a pain here. Well, let's give you acupuncture. Let's put some electrolysis into that and stimulate that a bit more. When you were talking about that earlier, I had talked to 2 years ago, and I don't know the results of this, but there was a lady, an acupuncturist of Chinese medicine in California, using their 8-inch needles, guiding them into the tumor with ultrasound, or I'm not sure if it wouldn't have been a CAT scan, so it had to be ultrasound, guiding it into the tumor to see if that could stimulate some destruction of the tumor prior to having chemo treatment. Other than that, folks, I think we've answered all these questions. And Stephen, I want to thank you very much. Your knowledge is great, and then beyond that. So we all appreciate that. I'm sure everyone here listening or still with us would attest to it all. So without further ado, I shall pass it back. Thank you, Steve. Pass it back to Aaron
Thanks.
for our final wrap up.
Yes, thank you guys so much. That was a really great presentation. Really great questions and information that we sort of dug into. And I really appreciate everybody asking all the great questions. I really appreciate your answers, both from the patient perspective and from the research perspective and knowledge perspective. I think that was really, really great. Lots of thank yous coming in the chat. And people really appreciating the time today. So thank you both again so much. We really appreciate you taking the time again on the long weekend, and really appreciate everyone for coming out on the long weekend. If there are any additional questions that anyone has, please feel free to send me an email. It's erin@craigscause.ca, ERIN, and I'm happy to get those sent along to Stephen or to Ben, whoever the question is for, or if I can answer it, I can help to answer. But yeah, otherwise, are any final sentiments, Steve or Ben?
No, I think
The
that's great. I'm glad Ben mentioned about that you have to be an advocate. And I just wanted to say that if you feel that you don't have enough background to be an advocate in the U.S., the Pancreatic Cancer Action Network will assign a patient to sort of guide you, or they will hook you up if you're a caregiver with another caregiver or a patient to help guide it. And I've actually gone on appointments with patients, which, I would ask them if they really had very little knowledge, said, just clear it with your surgical oncologist or oncologist. And I've driven up to 4 hours away to go with them on their appointments, help them ask questions and help interpret questions. And I wish there were more people like me that would be in that capacity to do that, because I think it's a really valuable thing that people can use to have somebody go with them to help interpret.
Okay, Aaron, the only thing I wanted to add in, well, it's not even add in, just you, Steve, and I will stay for a wrap up. That was all.
Sure.
But
Yep.
once again, thank you, everyone.
Yes.
All right. Thanks, everybody.
Thank you so much, everyone. Again, if anyone needs anything, please feel free to email anytime. And hope everyone enjoys the rest of your long weekend.